We'll start with basically the background. How many people here know what the female athlete triad is? You should all raise your hands today if you came yesterday. And this is a very biased crowd because you're already very educated, so it's great to see that many people raise their hands. Can you all hear me? I'm fairly loud. The thing that kind of brings us all together on this panel is we're all involved with the Female Athlete Triad Coalition, which is this international consortium of really bringing in different people that have a passion about the triad, whether they're clinicians or they're researchers or they're advocates or they're coaches. So it's really great to have all these people in one place. So what is the triad? You know, it used to be, we thought it was disordered eating, amenorrhea, and osteoporosis. And it was a term that was coined in the mid-90s. The ACSM came up with a position statement in 1997. And they said they were seeing this combination of really disordered eating or anorexia, bulimia, really severe forms of disordered eating, and then amenorrhea, loss of menstrual cycle, and then osteoporosis, really bad bone density. But then as we progressed, about 10 years later, they came up with another position statement from ACSM in 2007 and said, you know, it's really this concept of energy availability. Some people aren't trying to be anorexic. They're not trying to be bulimic. They might not have enough calories in their system. So it's really a spectrum of different types of lack of nutrition or not enough calories for how much they're expending with their sport. With amenorrhea, it doesn't have to be a full-blown loss of menstrual cycle for 3 months. It can be some menstrual irregularity. It could be anovulation, luteal phase defects, but some abnormality in the menstrual cycle. And then instead of just all the way to the severe form of osteoporosis, it could be really any type of poor bone health. So a woman who gets multiple stress fractures, a person who has lower bone density than we would expect for her age. So it's really this continuum. And a lot of you guys saw this slide yesterday in Dr. Quinn's talk and in one of my hormone talks. At the right end, we have a great part of the triad. We have optimal energy availability, you have optimal bone health because the woman is doing weight-bearing sports and she's getting normal menstrual cycles, so she's getting all that hormonal input, which is important for bone density building. So we want all our athletes to be up in that right corner. And then where we see a lot of our athletes in clinic and a lot of the people that we study, they're really kind of in the middle. They may be an athlete who's lost their menstrual cycle a little bit, or they've gotten their menstrual cycle was delayed, or they have some eating issues, or they've had more stress fractures than we would expect, and they're starting to go down a slippery slope. So the take-home point is if you see one aspect of the triad, pay attention. So what's the prevalence? Again, I really want to emphasize the prevalence of the components of the triad because it's not as often that you see a girl with a really severe form of all 3 components of the triad. But these numbers are pretty startling if you ask me. So basically up to 78% of high school varsity female athletes are found to have 1 or more components. Up to 62% of female college athletes have disordered eating. Up to 66% of female athletes are amenorrheic. When studied over 3 months, this was a great study. This was a study where they actually had women giving samples for every single morning. They gave lab samples every single morning for 3 months. Those are dedicated research subjects. And they found that in these recreational runners who actually got their period, whoa, I got louder. Which is not what you needed from me. I'm already caffeinated. 78% of these recreational runners who actually got their period had at least 1 irregular cycle. They had anovulation or they had a luteal phase defect. So again, when we can actually do these studies where we're testing the labs and we have really good, appropriate lab testing availability rather than just doing surveys, you know, more menstrual irregularity than we would probably think is expected. And then we also found low bone mineral density in 38% of adolescent athletes with amenorrhea. So I hope I'm driving home the point that this is prevalent. You know somebody who has this. You know you've treated someone like this. You've coached someone like this. So we all have to come up with better strategies. So low energy availability, again, we used to think of it about eating disorder. There's this psych book, DSM-4. They're coming up with the DSM-5. And basically, it was a clinical mental disorder that was characterized by abnormal eating behaviors, an irrational fear of gaining weight, and false beliefs about eating, weight, and shape. But disordered eating really covers the gamut. It could be various abnormal eating behaviors. So restriction, fasting, frequently skipped meals, diet pills, laxative, all those things are all obviously abnormal eating behaviors. The menstrual cycle, if you came to the hormones talk yesterday, you were beaten over the head by the menstrual cycle. I'm so proud of all the men who have stayed for yet the second day to hear more about the menstrual cycle. And I'm going to tell you about it again. So you will be very educated about it. Day 1 is the first day of the menstrual bleed. That's the early part of the follicular phase. Then into the next section, we have the follicular phase where estradiol increases. That causes the buildup of the endometrial lining. Then there's ovulation. The egg is released, and then progesterone is produced from the corpus luteum. So progesterone maintains the lining. So the thing to remember is estradiol builds the lining, progesterone maintains the lining, and then if there's not a pregnancy, there's no fertilization, that corpus luteum involutes, and that progesterone drops suddenly. And that's what we want to happen. It drops suddenly, and then that lining is shed. It's a normal part of life. Women have to deal with it, and it's good for us. So how is this all working? Basically, up in the brain, in the hypothalamus, there's something called GnRH, gonadotropin-releasing hormone. And it signals FSH and LH from the pituitary. The anterior pituitary is right behind our nose, so you would go right through the nose to get to the pituitary. Don't do it, but if you ever need pituitary surgery, that's how they're going to do it. So the GnRH tells FSH and LH to do their thing, and they stimulate the ovaries. And so that's the whole hypothalamic pituitary axis that's involved with menstruation. So what happens in people who are female athlete triad, hypothalamic amenorrhea, whatever term you want to use? This is a great study that was done by Dr. Mansoros, where he actually looked at prepubescent girls, so girls who are healthy, haven't gone through puberty yet, adult women, and then hypothalamic amenorrhea patients, so women who are not having normal cycles because of this energy availability deficit. And I hope you can notice the pulsatility of LH and FSH. Before we go through puberty, they're just kind of chilling out, not a lot of pulses. During adulthood, they're having these pulses all day long. Hypothalamic amenorrhea, those pulses are disappearing again. So we're missing those pulses if patients are having amenorrhea. And this is just talking about 2 hormones, FSH and LH. There's a lot of different hormones that are disrupted. But it was a very elegant study that really demonstrated that these girls are acting like they look like they're prepubescent, which isn't good for bone development. So you've seen this slide again. It's one of my favorite slides, and you've seen it from a few different people now. And this stat that we keep throwing out, 90% of women's peak bone mass is accrued by the age of 18. Why do we care? Because if we can't build up as much bone as possible during adolescence, we're already going to have to go through menopause and drop a bunch of bone density because we're going to have estradiol drop and a lot of other hormones drop. So if we don't get to that peak bone mass, we're going to get osteoporosis. We're just not going to be able to avoid it. So these kids who are 17 and don't care that they don't get their period, they're psyched because they're runners, they're thin, they're fast, they're not thinking about osteoporosis, they're going to be in trouble. And so as clinicians and as coaches, we have to appeal to them in terms of their performance and the fact that female athlete triad does affect performance. But in the back of our minds, we have to remember they're going to break. If nothing else, they're going to break their bones while they're trying to be good athletes. And later on, they're going to have osteoporosis at a much earlier age. So we want to prevent that. We're all about prevention. And we want to get them to that peak bone mass when they're building all that great bone density during their adolescence. So that's my pitch. And now we'll have our next speakers. I'm going to tell you about our first one, who is Dr. Jean Nichols. Dr. Jean Nichols is the president of the Female Athlete Triad Coalition, which I mentioned is an international consortium of researchers, clinicians, and others interested in triad treatment and prevention. We're all involved with the coalition, but she is our fearless leader. She is a recently retired professor of exercise and nutritional sciences and the co-director of the Center for Optimal Health and Performance at San Diego State University. She's now a research scientist at UC San Diego. I'm glad that the weather got nicer for Jean because yesterday and the day before weren't really appealing to her. Dr. Nichols' research focuses on exercise and bone health across the lifespan. She's currently investigating energy availability and its association with bone turnover in female high school distance runners. Her professional memberships include a fellow status with the American College of Sports Medicine, the California Governor's Advisory Committee on Physical Fitness, the American Society for Bone and Mineral Research, and the International Society for Clinical Densitometry. She got her BS locally here at Northeastern University in exercise science and health education, her master's at UNH in exercise physiology, and her PhD at the University of Michigan. Please welcome Dr. Nichols.
I can't remember that far back, some of that history. It's really great to be back in Boston and to be part of this conference. Really exciting to be here. And I say back in Boston is because I was born and raised here, lived in the city for several years before going on to graduate school. And if you detect a little bit of a Boston accent, although I've been gone 28 years now, I spent the last 2 days with local family and friends, and it just comes back. So anyway. Okay, well, my primary research interest, as Kate said, is the adolescent athlete, primarily on energy availability and bone health. And the focus of my talk today is going to be on bone health as it relates to the other triad disorders. So let's move ahead. So why do we care? What is it? And let me say too that all of our work has been on the high school interscholastic athletes. So I'm not talking here about some of the elite adolescents that have been studied in more case studies throughout for several years. But until early 2000s, we hadn't had any data on high school athletes and the triad. So we set out to do that. And, you know, it's really important to me, and you saw from Kate's data that on the prevalence of this problem, but what the numbers do not show is the real personal toll on these young girls. And as president of the Triad Coalition, I'm the one that receives the email messages sent to the coalition from athletes, sometimes parents. And I'm so disturbed at the frequency at which I receive these and the seriousness of them. And here is just a quote I wanted to share with you to really show you the personal side and the personal toll this takes. I think if you can all read it from the back. I think I have and this is a direct quote from her, I think I have disordered eating and excessive exercise problem. I spend all day thinking about food and eat just enough to run and get through my daily routine, which is running 8 miles a day. So from 5 a.m. to, she eats 500 calories from 7 a.m. to 6 p.m. night, runs 8 miles a day. And then she says, I eat at night a large, and that's my emphasis on large, dinner that boosts my caloric intake to probably about 1,500 because I hate to go to bed hungry. I know I'm underweight, 95 pounds and 5'3", and I know I need to gain weight, but I'm afraid if I start eating regularly, I will gain too much. So if you do the numbers in your head, 95 pounds and 5'3" puts her body mass index, or BMI, at 16.9. So she's below the cutoff. She meets one criterion for anorexia nervosa. So, and this was a 16-year-old runner writing in. So I'm happy to say that the coalition has begun now a physician referral network where we can try and seek help for these young athletes from around the country and internationally. The other reason that I'm interested in adolescent and high school athletes is, and Karen actually just kind of showed you on the slide, but you know, we used to think of osteoporosis as a disease of little old ladies, right? Oh, and it wasn't men, it was just little old ladies. And now there is this notion, this feeling that it's really might be a pediatric disease that just takes years to manifest itself in middle and old age. Lifetime accumulation of bone mass measured as bone mineral density, or BMD, and that's by an X-ray procedure called DEXA, and that may have been mentioned yesterday. And so what you see, as Karen showed you, is that it's during youth and adolescence that we rapidly gain, you can see the steepness of this curve, rapidly gain bone mass until we reach our peak, and after that it's pretty much all downhill, with not too much that we can do behaviorally anyway to affect our bone density after peak. So depending on whether you're an optimist or pessimist, we can look at this period of time as either a window of opportunity to gain mass, or and it is also a window of vulnerability. And so when things go wrong, we want to try and prevent before they reach that peak. So I need to go on record. You're going to see some data that are kind of disturbing on what happens to our bone health when things go wrong with the other parts of the triad. But first, I just want you to make everyone to make sure that you understand that I am a strong proponent of of sport and exercise for women and young girls and for everyone. And so I don't know if anyone covered yesterday really how does exercise promote bone health, but this is a model used by a colleague at Indiana University from Alex Roblin's lab. He shared this slide with me. This is a rat forearm in a device that can deliver an exercise prescription, if you will, in terms of the amount of force, the amount of load on that bone, the rate at which that load is applied, the duration and frequency over a week at a time. So you could sort of look at this device as a personal trainer for the rats in the lab, okay? And so everything is controlled. And so these impact forces on bone, as you can see, cause a bending. And if the impact gets too great, as in, say, falling off a bicycle, where the impact is beyond what the bone can handle and the bone fractures, but they can test, how does bone mass accumulate and how much with this exercise prescription. So if you rather think of this in human terms, you can kind of look at this as this volleyball player, every time she goes up to spike the ball, she's getting impact forces in the bones that are in that part of the body that where the muscles are working. Okay, so bone exercise is very site-specific. If you want to build bone in your legs, you can't do just arm exercise. Okay, and the other form of exercise that promotes bone health, as I think probably everyone in this room knows, is resistance training. And it has to be fairly intense, somewhere around at least 75 to 80% of the one repetition maximum. So kind of high intensity strength training. And the tendinous attachments to the bone, pulling on that bone with muscle contraction, will promote gains in BMD. So that's all the good side of it. And if kids are doing impact exercise, and it doesn't have to be organized sport. Kids used to play jump rope a lot and hopscotch, and we don't see that too much anymore. But all of these, this type of exercise is really important. Okay, so now let's kind of look at what kind of goes wrong sometimes. So our research team for now a decade, it hardly seems possible, a decade we've been doing this work, started to first look at the prevalence of the triad in high school athletes, and this is in Southern California, actually in San Diego County, high schools across the county, and to determine those prevalence estimates of each of the triad disorders. And then after we did that first epidemiologic study, which was in about 689 athletes, and then from that group we had bone scans, actually bone DEXA measures on 170. So the publication actually from this was with 170 athletes. And this is from every interscholastic sport that's offered in Southern California. And then we started to observe that the biggest problems were in the distance runners, cross-country kids and the milers on the track team. So in our subsequent studies, we started to look at the runners in sports that are been given the name in the literature, not lean build athletes, and actually these are the sports of the so-called non-lean build, and I don't really like that terminology, but anyway, we went with this because it's what the literature was showing in college athletes. So that gives you an idea of what the comparison. So we compared runners to all of these other athletes. Okay, measures we did to get at disordered eating. We used the Eating Disorder Examination Questionnaire, which is a self-report where girls report, ask questions of, do you restrict calories to control your body weight? Do you eat in secret? Those types of questions. And maybe it's certainly the dietitians in the room and nutritionists are familiar with this. And it's a standardized questionnaire. And then we also had self-reports only of menstrual history, so no hormones for these first studies, no blood work, just all self-report. And then for a subsample, again, we brought them into the lab and did their DEXA measures. Okay, and whoops. What have I done? Okay. All right, so I'm just going to show you just a few results because we certainly don't have time for a lot. So this first slide is showing you the influence of dietary restraint. So one of the subscales of the eating disorder examination questionnaire, there's, I think, 5 questions that get at whether the respondent is consciously restricting calories to control their weight or their shape, or for performance, or it's a conscientious restriction. And the 3 bars are showing you from the left, the light gray is those with normal eating behavior by the EDEQ. And then the center bar, those who had on the subscales for elevated shape concern or weight concern. And our feeling is many high school kids do have concerns of weight and shape, and often they're benign, but sometimes they can lead to worse conditions. And then those with elevated dietary restraint on the right. And I just drawn these lines here, so I need to just maybe quickly explain what a BMD Z-score is. So we measured bone density, and then to compare to other girls in the same age group from a reference population, we use what's called a Z-score. Okay, so it makes for easy comparison. And the red lines are showing you that what's considered normal according to the Society for Clinical Densitometry, in between plus and minus 1 on a Z-score. To put that into perspective, a Z-score of plus 1 is about 10% greater bone density than a 0. So if a girl was right on average, then her Z-score would be 0. Okay? If her bone density is about 10% higher than average, she'd have a Z-score of 1. 10% lower, minus 1. So anything within those red lines is considered normal. So what you can see very clearly here is that girls with elevated dietary restraint, and this was a small, about 6 or 7% only in this sample of 93 runners, had pretty severely low Z-scores already at age 16. Okay. Next slide is showing you the influence of menstrual status on their BMD Z-score. So the same setup on this graph. And here we're looking at 2 bone sites, their total body in light gray and then their lumbar spine. And if you read with me from right to left, we're going from normal. I don't know if you can you see the numbers at the bottom of the screen. So this is looking at how their bone density compares by their number of menstrual cycles in the past 12 months. So girls with normal menstrual cycles, and that's somewhere in the 10 to 12 range, had, again, normal Z-scores, and I'll show you the line there at about a minus 1. So as we go then for moving right to left, we see that right on the cusp, those girls who were in most of these 4 to 9 cycles, most of these were oligomenorrheic, so delayed cycles. And then we get into those with secondary amenorrhea and those with either primary amenorrhea, or it could have been secondary amenorrhea, but 0 cycles in the past year. So they may have had onset of menses and then stopped cycling for a whole year. So once again, you can see a pretty severe influence of low of menstrual cyclicity on bone mass. All right, and then for the athletic trainers in the room, I wanted to just show this slide on injury. So my colleague Mitch Rao, who is a physical therapist, and his interest is on how the triad relates to injury. And so what we're looking at here is the white bars are the normal behavior for each triad condition. And left to right, we're looking at normal EDEQ score overall, so an average of their eating disorder score, and then just looking at the dietary restraint subscale of the EDEQ, and then the menstrual status, and then normal and low bone. And the numbers at the top of each bar are the percentage of athletes that presented with a severe injury, serious injury, which was categorized as missing practice or competition for more than 22 days, consecutive days. Right, so, and what do you see? In all of these, each of these were statistically significant difference between normal and abnormal, except for the menstrual, and that was just, again, kind of right on, I think the p-value value for that was like 0.18. So this difference here was not statistically significant, but again, clinically, we're starting to see that something's wrong here. And I want to say, too, that these injuries are not just stress fractures. So Dr. Rao is, I think, the first person to show that in other injuries, sprains and strains seem to have something going on here in this, and we have sort of a working hypothesis of why that might be so. We don't have time to talk about it now, but these data were kind of disturbing when we found them. And lastly, comparing the runners to these so-called non-lean build athletes. And in this, we asked the question, and this is in cross-sectional data. We wanted to see the effect of age from the time they were freshmen through seniors. So again, we're not following the same girls here. We're looking cross-sectionally, and that's an important point to be made. But it's z-scores going from 13 to 14, 15, 16, 17 to 18. And so what we should be seeing, in fact, what we really like to see is what's happening with these non-lean build athletes. That as they get older, okay, with increasing age, we're seeing a tendency toward, and I don't know what went on here at age 15, but certainly by age 16 and 17, we're seeing gains in their z-score. So this is showing that beneficial effect of loading and resistance exercise through their sport on their bone health. All right, their bones are getting more dense during that growth phase. And that's a good thing. But we see just the opposite here with the runners, that they're actually getting worse. And so we we interpret these data as saying that these girls are not accruing or building bone at the rate that we'd like to see them. And even if they were just building normally, then those z-scores should be equal across time, but they're clearly getting lower. So we have started trying to look longitudinally. We do have some 3-year longitudinal data that, again, not enough time to show you, but the data are a little disturbing in that some girls that started low are just not getting better. And so they're setting themselves up, as Dr. Ackerman mentioned, for potential for osteoporosis at an earlier age than we'd otherwise would see. So let me just wrap this up then quickly here. Clearly, during youth and adolescence, it's a time of opportunity to build bone. And everything that we can do, and I'm not mentioning here any of the dietary influences, but clearly there's a dietary component to it, but impact and resistive exercise is good for our bones. In contrast to that, in individuals, athletes who restrict their energy intake, and then I put, or inadvertently do not consume enough calories to balance their high energy expenditure. And we don't yet have really good data on how many girls are say, normally eating. They don't have any disordered eating, yet they're just not getting enough calories. And we suspect we're seeing this in some of the runners. They require a lot, especially at this age through development, and they're just not getting it. And then an important message, because I often hear I hear it just much too frequently from athletes. I hear it from some coaches, and sometimes I even hear it from primary care physicians that are telling their athletes, well, it's okay to, not have your menstrual period for the season as long as you get it back. And the data now just not supporting that. Amenorrhea is not normal. And lastly, all of us, the team approach, the athletes need to be obviously directly involved, the coaches, the parents of these young kids. Athletic trainers need to be involved. And we need to do this team approach to really stop this, to prevent this from happening. So with that, then, Kate mentioned the Athlete Coalition, and I thought I'd get a plug in. If you haven't seen the webpage, I invite you to take a look what we're doing, and I'm happy to say that one of our priorities for this 2013-2014 is the high school athlete, and trying to incorporate some programs that, some training, some materials. We're kind of thinking about social media as a way to deliver this message. So with that, then, I just want to acknowledge our Project Spirit research team, and of course our funding agencies. So thank you, and I think we'll have time for questions after. Okay.
Dr. Misra went to medical school at the SCB Medical College at Utkal University in India. I'm also going to butcher these names. And residency in OBGYN at the Institute of Medical Sciences in Varanasi, India. She did a residency then, another one, in pediatrics at SUNY Downstate in Brooklyn. She did a pediatric endocrinology fellowship at Massachusetts General Hospital and achieved her master's in public health at the Harvard School of Public Health. She's currently an associate professor at Harvard Medical School. She's the Pediatric Endocrine Fellowship Director, the Pediatric Research Director, and the Neuroendocrine Sports Medicine Research Lab Director, all at MGH. She's received numerous awards for her research, having published over 100 articles, chapters, and reviews specifically on triad, eating disorders, and bone health alone. She's currently the principal investigator or co-investigator on numerous NIH-funded projects related to triad or anorexia, with a particular interest in adolescent female athlete triad. Please welcome Dr. Misra.
Thank you very much, Kate. That was an awesome introduction. So my charge is to discuss with you bone structure and strength in endurance athletes and non-athletes. And much of the data that I'm going to show you today is based upon a study that Kate and I are doing together. And before I go on to the data from the study, I'd just like to show you what bone looks like. So bone is mineral, calcium phosphate, that's deposited on a framework of collagen, which is a protein. And when you look at long bones, there is this outer shell of bone, which is cortical bone. And then at the ends of long bones and in the flat bones of the body, the vertebrae, the ribs, we have this spongy bone or trabecular bone. So the study we're doing is in teenage and young adult athletes, endurance athletes between 14 and 21 years old. These are all normal weight athletes. And we're studying athletes who are amenorrheic, have lost their periods. Those who are eumenorrheic are getting the periods, and non-athletes. Everybody gets a DEXA. And we're also studying bone structure by high-resolution peripheral quantitative computed tomography, or HRPQCT, much shorter. And we're looking at the distal radius and the distal tibia. I'll come back to these in a minute. And we're trying to differentiate between the effects of physical activity versus the loss of periods on bone structure. So here's a look at the data from DEXA measures of bone density. So here are the Z-scores that Dr. Nichols talked about. And you probably can't see this, but these are measures of bone density at the lumbar spine. And this is bone mineral apparent density at the lumbar spine, which is a height-adjusted measure of bone density. And then we have the femoral neck and the total hip. In red are the girls who are amenorrheic, have lost their periods. In yellow are the eumenorrheic athletes who are getting the periods, and in green are the non-athletes. And at the spine, we found that measures of bone density were significantly lower in the amenorrheic group compared to the other two groups, much like the data you've seen from Dr. Nichols' study. And at the hip and the femoral neck, the humano-weak athletes had higher bone density than the non-athletes. But this advantage was really lost in the amino-weak athletes who had lower bone density than the humano-weak group. Now, high-resolution peripheral QCT is a technique that allows us to characterize not just bone density, but bone geometry, and it measures not aerial bone density, which is what DEXA measures, but volumetric bone density. And the advantage of volumetric bone density is that it's not susceptible to erroneous readings from differences in bone size. So aerial bone density will overestimate bone density in tall girls and underestimate bone density in shorter girls. But volumetric bone density gets around this issue. And QCT also allows us to assess the cortical and the trabecular compartments of bone separately. So we looked at the distal tibia and the distal radius and the distal tibia. So the radius, as you know, is one of the long bones of the forearm. The tibia is one of the long bones of the lower leg, and the radius is non-weight-bearing bone. The tibia is weight-bearing bone, which is why we looked at both of those sites. So at the tibia, we found that both groups of athletes, the amino-weak athletes and the humano-weak athletes, had greater cross-sectional area of bone than the non-athletes. And this should be good for bone because the wider your bone is, the stronger your bone is. But what we also found was that the amino-weak athletes, shown here in red, had lower cortical thickness than the humano-weak athletes and the non-athletes. So if you look at this outer rim of bone, this thickness was lower in the amino-weak athletes, and this is really a very important determinant of bone strength. And the lower cortical thickness you have, the lower is your bone strength. Now here's a look at the trabecular structure. So these are the spicules of bone that form the trabeculae, the spongy bone. And if you look at this picture, which is from an amino-weak athlete, this is an humano-weak athlete and a non-athlete, you can see that the trabeculae are further apart and fewer than in the other two groups. So trabecular number was lower and trabecular separation was higher in the amino-weak athletes compared to the other two groups. Now, what about bone density? So here is trabecular volumetric bone density. This is total volumetric bone density, and both were significantly lower in the amino-weak athletes compared to the other groups. Now, at the distal radius, which is non-weight-bearing bone, again, we found the trabecular bone density was lower in the amino-weak athletes compared to the non-athletes, and there was kind of a trend there. Now, we next used finite element analysis to assess bone strength. So this is a cool technique. And what this does is it applies virtual compressive forces to models of bone developed from HRP-QCT. And then it measures bone strength in terms of the breaking stress of bone. And the measures we get are bone stiffness and failure load. And here's a look at bone stiffness and failure load at the tibia and at the radius in the three groups. So at the tibia, which is weight-bearing bone, the humano-weak athletes had greater stiffness and failure load than the non-athletes, so that's greater bone strength. But again, this advantage was lost in the amino-weak athletes who had lost their periods. And at the radius, bone stiffness and failure load were both lower in the amino-weak athletes compared to the non-athletes. And I hope you can see this section of the slide. So this is a cross-section of the distal tibia, the distal radius in one amino-weak athlete, humano-weak athlete, and non-athlete. And the more yellow and green there is in the bone, the stronger the bone is. The more red there is, the weaker the bone is. And as you can see, the humano-weak athlete has more yellow, so that's stronger bone as compared to the other two. And at the distal radius, the amino-weak athlete has a lot of red, which means this is weaker bone. Okay. So to summarize these data, amino-weak athletes have lower spine bone density measures compared with humano-weak athletes and non-athletes. Humano-weak athletes have greater bone density at the hip and the femoral neck compared with the amino-weak athletes and the non-athletes. So this advantage that the humano-weak athletes have is lost in the amino-weak athletes. In terms of bone structure, athletic activity per se leads to a greater cross-sectional area of bone at the tibia, which is a weight-bearing site. But amenorrhea, or loss of periods, leads to a decrease in cortical thickness, a decrease in trabecular number, and a decrease in trabecular and in total volumetric bone density. Now, when we think about the increase in bone accrual that occurs during adolescence, there are many factors that contribute to this. There are genetic factors. Nutrition is very important. Physical activity is important, as we heard from Dr. Nichols. Calcium and vitamin D intake are important as well. But particularly in the adolescent, the pubertal years, we have rising levels of estrogen, which is very important for preventing bone loss. And we have rising levels of growth hormone and IGF-1, or insulin-like growth factor 1, which are bone anabolic hormones and increase bone formation. So we have an increase in bone formation from rising levels of growth hormone and IGF-1, and we have a decrease in bone loss from rising levels of estrogen. And together, these hormones can be really very, very important in optimizing bone accrual in the adolescent years. So what are the mechanisms that contribute to low bone density and poor bone structure in athletes who have lost their periods? So low energy availability, a lower body mass index you've heard about already. So it's important to implement measures to increase or optimize nutritional status and or reduce activity as may be necessary at times. But this low energy availability also leads to many other hormonal alterations. It causes low levels of estrogen, low levels of IGF-1, alterations in some of the appetite-regulating hormones, and cortisol levels go up. And these can all impact bone, as I'll show you in a minute. And then I'll talk briefly about calcium and vitamin D intake. Now, just a brief word about lean mass or muscle mass. So this is a very important determinant of bone density. And individuals who have the lowest lean body mass have the lowest measures of bone density at the spine and at the hip. And although in this study, the amino-weak athletes did not have significantly lower lean body mass than the other two groups, you can see that there definitely was a trend. Now, moving on to estrogen. So amino-weak athletes have lower levels of estrogen and also testosterone than eumino-weak athletes, shown here in orange and yellow respectively. And these hormones are anti-resorptive hormones. They prevent bone loss. They may have some bone anabolic effects. And women who have the lowest levels of estrogen, the longest duration of amenorrhea, and a later age at menarche have lower bone density measures at the spine and for the whole body. So this would suggest that estrogen should be a very effective strategy. Replacing estrogen should be an effective strategy to try and increase bone density. But when we look at the studies of oral estrogen given as a birth control pill, they really are by no means definitive. So while a couple of studies have suggested that bone density may go up with estrogen, the majority show no change in bone density with estrogen, and a couple suggest that bone density might actually go down with estrogen. So we really are in need of more studies that better address this question. Most of these studies are either very small or not randomized, and so we definitely need a better study design, and I'll talk about something that we're doing a little later. So IGF-1. So IGF-1 is a bone anabolic hormone. It increases bone formation, and amino-weak athletes have lower levels of IGF-1 than non-athletes. The eumino-weak athletes are in between, and women with the lowest levels of IGF-1 have the lowest measures of bone density. Now, importantly, oral estrogen, so estrogen given as a birth control pill, can suppress IGF-1 levels when it gets metabolized through the liver. And this may be one of the reasons why oral estrogen is not more effective in increasing bone density. And interestingly, when estrogen is given as a patch, when it's absorbed through the skin rather than taken orally, that does not suppress IGF-1. And a potential way to give estrogen that is more effective than oral estrogen is the estrogen patch. And do we have any data for this? Well, we have none in the athlete with amenorrhea, but we did a study in adolescents with anorexia nervosa in which we randomized the girls with anorexia nervosa to the estrogen patch shown here in yellow or placebo shown in red. And we also looked at non-athletes for the study duration, and these non-athletes are shown in green. So this figure shows the percent change in spine bone density over 6, 12, and 18 months of the study in the three groups. And the girls who received estrogen as the patch had a significant increase in bone density over the study duration than those who were randomized to placebo. And the increase in bone density really approximated that in controls. So this was encouraging. But again, we have no data in the athlete with amenorrhea. Now, just a very brief slide on the appetite-regulating hormones. So ghrelin is a hormone that increases appetite, and it's made by the stomach. High ghrelin levels are known to be protective to bone, and amino-weak athletes have higher levels of ghrelin than non-athletes and eumino-weak athletes, suggesting an adaptive response. Now, leptin is made by the fat cells and it inhibits appetite. High leptin levels are known to be protective to bone, and amenorrheic athletes have lower levels of leptin than the other two groups, which could be deleterious to bone. And PYY is a hormone that's made by the distal gut, and this is a hormone that inhibits appetite. High PYY levels are known to be deleterious to bone, and amenorrheic athletes have high levels of PYY, which could be deleterious to bone. And in fact, we've found that the amenorrheic athletes with the lowest levels of leptin and the highest levels of PYY have the lowest measures of bone density. Now, cortisol has multiple deleterious effects on bone. I won't go through this, but amenorrheic athletes have higher levels of cortisol than eumenoric athletes and non-athletes, and this could also contribute to low bone density. Now, calcium and vitamin D intake are obviously important. It's essential to try and maintain vitamin D levels above 30 nanograms per ml. In our studies, we've always found that the amenorrheic athletes tend to consume more calcium and vitamin D through intake of supplements than the other groups, likely because they're concerned about the impact of amenorrhea on bone or have heard about this from their providers. So to summarize all of this information, determinants of low bone density are reduced energy availability, low levels of estrogen, alterations in IGF-1, leptin, and PYY. And it's important to optimize weight and or reduce activity, so optimizing nutritional status is really key. Estrogen replacement seems like a good strategy, but we know that oral estrogen is probably not very effective. We have an ongoing study at Mass General comparing oral estrogen with transdermal estrogen versus no estrogen in athletes who are amenorrheic. And so for people around who work around this area, if you have patients who meet these criteria, we will welcome them in the study. So do get in touch with Kate or me or any of us who are doing the study. And I think you probably have flyers about the study in the bags. Now, importantly, just replacing estrogen is not going to address the increase in cortisol and PYY or the reductions in leptin and IGF-1. And these are really best addressed by optimizing energy availability and nutritional status, and that is important to remember. So thank you very much, and I'd like to also thank Kate Ackerman, who works with me on these studies, and our study coordinators who do a phenomenal job. So Lisa Pierce is here, and I think Gabby Gureca is here as well. Megan Slattery is one of the nurse practitioners who works on our studies and does an astounding job. And Hannah Clark is our current study coordinator who's carrying on the flag that Lisa and Gabby started off carrying. So thank you.
Thanks, Madhu. Okay, so moving on to our next speaker, Dr. Ron Thompson. Dr. Thompson earned his BA in psychology from the University of Oklahoma, his master's in educational psychology at the University of Oklahoma, a master's of arts in psychology at St. Mary's University, and then a doctorate in philosophy in counseling psychology at North Texas State University. On a side note, he and his business partner are happily married to other people. However, they are a testament to having a work marriage. He is in private psychology practice in Bloomington, Indiana, with his business partner and friend, Dr. Roberta Sherman, and this week they celebrate their 27-year partnership. They are now the co-directors of the Victory Program in Missouri. This kind of relationship really demonstrates what you can get done when you collaborate. And so just telling you a few things on his CV are pretty remarkable. They've been involved with Indiana University's Department of Intercollegiate Athletics since 1987. They're members of the National Eating Disorder Association, and in 2010, they helped develop the National Eating Disorders, or NEDA's, Coaches and Trainers Toolkit regarding eating disorders and Triad. With the NCAA, they developed the NCAA Coaches Handbook, again, managing the female athlete triad, a guide for coaches. And then they're members of the Academy for Eating Disorders and helped begin an interest group and workshop on athletes with eating disorders and received the Academy's Leadership Award for clinical, administrative, and educational service. They also are the co-authors on the position stand on the female athlete triad for the International Olympic Committee. And this is just a smattering. Like I said, all of these people are impressive. So please welcome Dr. Thompson.
I think there's a common misconception in the sport world is that dietary restriction, weight reduction, excessive training by athletes are primarily for the purpose of losing weight or body fat in order to perform better in sport. I wish that were the case. They'd be a lot easier to treat. Many of the athletes that I treat with disordered eating, and certainly those with eating disorders, would have their disorder without having been an athlete. Eating disorders, potentially life-threatening disorders with multiple determinants and factors. I get frustrated sometimes when I hear people talk simplistically about where eating disorders come from. It's a host of factors, not the least of which is genetics. In fact, the most interesting and stimulating research that's gone on in the last 10 years relates to the heritability of eating disorders. But certainly participating in sport can be an additional risk factor. Well, what does all of this mean? One of the things that we do in our program is that every athlete that we see, one of the first things we try to do is to determine what's the relationship between sport participation and eating disorders. And let me say, first of all, you're not going to find a bigger sports nut anyplace. Roberta and I steadfastly believe that in our society, young women and girls need healthy ways to compete. And what I mean by compete, I mean something other than competitive thinness and how to be attractive and so forth. And we think sport is one of the ways to do that. We don't have a problem with sport. We don't have a problem with sport participation. We have a problem with some risk factors in the sport environment. Sometimes people say, oh, it's the sport that's the cause, and they need to get out of their sport. I would never recommend that. It's not the sport. There may be some aspects of sport that increase their risk. Same thing I hear, oh, it's the coach. The coach is the problem. Coaches are not the problem. It's not that simple. But for all of you who are coaches, I will suggest to you that you have incredible influence and power with your athletes. And for that reason, you can play a role in either promoting or preventing disordered eating and eating disorders. And that's one of the reasons that Roberta and I have done so much work with coaches. Our feeling is that without the coaches on board, regardless of what kind of treatment program you put together, or prevention program like Carolyn Becker is doing, that's absolutely fabulous. Without the coach's endorsement and participation and support, it isn't going to work. So what we try to do is to see what's the relationships. Sometimes it's a direct relationship. Sport plays an integral role in the eating disorder. The sport participation may precipitate, let's get it started, or it maintain it. And maintaining the eating disorder. One of the things we try to focus on in treatment is always what is maintaining the disorder? What do we need to change? Choice of sport may have resulted from the eating disorder. They may feel pressure associated to decreased body size, body weight, body fat, or particular demands of a coach. But I got to tell you, in most of the athletes that I treat, and I've been treating people with eating disorders for 34 years. In most cases, sport plays a minor role in the disorder. And what I really mean by that is they would have an eating disorder without the sport. Now, certainly, sport participation is sometimes used by the athlete to rationalize. I hear it all the time. Oh, I have to be thin because I'm a distance runner. Okay, I understand that. But you don't have to be anorexic, and you don't have to be amenorrheic. So if they're not doing this primarily because of sport, why are they doing it? Well, I think sometimes there's a lack of information regarding the possible negative effects of health and performance. They want to be thinner, they want to be leaner, and that whole notion of competitive thinness. Does everybody know what competitive thinness is? I know all the young women do. That's this competition that goes on 24/7, 365 to infinity. And that is that you can't be thin enough, and if you see somebody who's thinner than you, you're not working hard enough. Competitive thinness. And it's in society, but it's also in sport. And one of the things that we try to emphasize is that sport is a microcosm of society at large. And whatever we see in society, we're going to see in the sport world. Risk factors in both places. And we think because the athlete has the same risk factors as non-athletes, plus those that are unique and specific to her sport environment, she's at greater risk. Enhanced performance, competitive tennis, unrelated sport, contextual body image. This is a relatively new term. It really has to do with some research that was done by Karin de Bruin. I'll talk a little bit later about it. And basically what it means is that Karin found that female athletes have two body images. And their disordered eating can be a part of that one that's based on society, that is outside the sport arena, or it can play an integral role in the one in the sport arena, or both. Okay, what are the other As a therapist, I got to tell you what I did. Unfortunately, in 2009 in November, my office was destroyed by fire. But before that, I had an office, and the waiting area was really a waiting hallway. And right across from where the patients were waiting to see me, I had this on the board. That is, the psychological reasons and issues. As I say, it's multiply determined. Eating disorders play unbelievable functions, purposes in the life of the individual. But I sometimes see those as reasons not to recover. And I've yet to see an eating disorder patient in my 34 years, which is now must be in the thousands. I've yet to see one that didn't have more reasons to keep her disorder than to get rid of it. And that's one of the reasons that it's so important that now when we work with athletes, we have some leverage. And that is, get back to sport, return to sport, perform better. And we use it. But these are all the things that an eating disorder can do in the life of an individual. I wish it were so simple as to say, oh, she's simply doing that because she's a distance runner. Well, maybe, but not very often. It's a lot of these things, too. And that's why sometimes it takes a long time in treatment. Okay. I was supposed to talk about what's happening in the world and sort of frequently, and this is a real treat for me because, as you will see, all of these folks I'm going to talk about are women, and I don't think that's a coincidence that the innovators here are women. But the good part is I get to be a part of all of it. Revealing Sport Attire, 2007, Roberta Sherman, my associate, that person that's put up with me for 27 years. And one of the things I've always said about that length of tenure is that if anybody deserves a life-size trophy emblematic of intestinal fortitude and mental toughness, it's got to be Roberta because she's still with me. But in 2007, Roberta was asked to come to an IOC meeting. And you'll see again who gets asked to come to these meetings. It's not me, it's her. And with good reason. Thank you. She presented for the first time the notion that female athletes are sometimes asked to wear very revealing uniforms. And our concern is twofold. One is that if those are so revealing that they make them body conscious, and they start to focus on body issues, it's likely to increase body dissatisfaction. And we know what happens after that, unhealthy weight loss practices. Well, it's not only that, but those revealing uniforms make unhealthy body comparisons very easy. You remember that competitive thinness thing we talked about? They'll do it as a young woman, and they'll also do it in a particular sport. Think about a diver who continues to get beaten by the same diver who might be thinner than she is. These are very complex issues, and unfortunately Roberta came back and she was crestfallen. She said, "We bombed." And I said, "What do you mean?" And she said, "Well, as I talked about this issue, all the women were nodding, and the men on the medical commission were saying, they didn't get it. They didn't get it. And in fact, the head of it said, "What's the big deal?" So she came back and, again, was lamenting. She said, "You know those Olympic rings we get to use on our slides?" She says, "That's probably over." I said, "Was it really that bad?" Well, here's the good part of the story, and Roberta is the eternal optimist, and she talks about planting a seed. 3 months later, this male physician, head of the medical commission of the IOC, called to borrow her slides for a presentation he was going to do. And as a result of that, we have a fabulous relationship with him now. And in fact, Roberta's going to be going back in November to talk with him about Triad issues. I think she's going to be talking about the role of the coach. So if any of you have any information or messages or concerns you'd like to send along, please let me know, and we'll send them. The next one, Ego versus Task Orientation Performance Mastery Climate. 2009, Karin de Bruin. Now, Karin is a sports psychologist in Amsterdam. Karin found that win-at-all-cost philosophy was associated with a greater risk of disordered eating. Imagine that. Those who focus on skill mastery rather than winning were less at risk for disordered eating. Well, I love Karin's work, and again, the good part of this is I got to be on her dissertation committee. This was part of her dissertation. This young woman had 4 major journal publications before the dissertation was conferred. Contextual body image. As I talked about this earlier. Again, this is one of the studies in Karin's dissertation. Reported that female athletes had 2 body images, one in sport and another in society, and that disordered eating disorder can occur in athletes who are satisfied with their bodies that fit the thin ideal for society but may not be lean or thin enough for sport. She's actually developed an instrument, so if you want to use that, contact me and I'll tell you how to do that. And prevention, Carolyn Becker. And I would suggest to you that if you've not heard Carolyn speak, you're going to have an opportunity shortly. Don't miss it. It's an absolute treat. I've heard her speak many times, and I will be there. Carolyn is doing such fabulous work on prevention. One of the biggest deficits in the eating disorder world are good prevention studies. We simply don't have any. Well, we do now, and it relates to Carolyn's work. And again, what's the treat for me? I get to be the consultant on her grant. So all these wonderful women have allowed me to tag along, and I am most appreciative. And as I said, later on today, I'm going to be talking about a multidisciplinary team approach. I think it's a multidimensional problem, so I think we have to have a multidimensional approach to treatment. You have to match it. For diagnosis and treatment, we need medical, nutritional, and psychological healthcare providers. I'm going to talk about how we put all those folks together and make it work. For management prevention, we also need assistance from sport personnel. I got to tell you, athletic trainers, we have athletic trainers here? People are fabulous. I simply would not work with athletes. We don't at Indiana without your help, and we certainly don't in our new treatment program. We have an athletic trainer who works with us. So thank you for all that you do. That's pretty much my update. Thank you.
Please, the gentleman.
Thank you.
So our final talk will be by Karen Sawson. She's our next dynamo. She's earned her BS in dietetics from Colorado State, her master's in nutrition with a concentration in exercise physiology from Long Island University. She has a private nutrition practice and is an adjunct professor at Long Island University and is a consultant for various schools and organizations. She has been a nutrition advisor for the New York State Public High School Athletic Association for over 20 years, where she is doing, among other things, the Female Athlete Triad Awareness and Prevention Program. She's in charge of that in the state. And now she's working with Normal in schools, which she's going to tell us more about. She's going to specifically talk about the Think, Eat, Play program, of which she is the tireless project director. And all the bracelets that we're wearing are advocacy bracelets that she made us this morning. Well, maybe she didn't make them this morning. She gave them to us this morning, and she has more. So welcome, Karen.
Thank you. Pinch me. I can't believe I'm on this panel. Unbelievable. So thank you. What an amazing conference. Thank you to Kate and to Whitney and to Dawn, and what an amazing agenda. So thanks for being here. Think, Eat, Play. This is incredibly exciting. It's the latest initiative through Normal in Schools, which is a non-for-profit that focuses on education about eating disorders and mindfulness. And really, it's inspired, all that we do is inspired by the Female Athlete Triad. Our goal is to optimize the health of adolescent female athletes, and we do that by providing education to coaches, athletes, health and physical educators, really important population, school nurses, administrators, and parents. And the topics that we really focus on are the Female Athlete Triad and its health and performance consequences. We talk a lot about guidelines for nutrition and athletic performance. That's a big piece of what we do. We talk about healthy body image and body satisfaction, and then, of course, we're getting into stress and performance anxiety educational materials. I've got the ultimate dream team. We've got over 40 leading researchers and clinicians, and to hear more about them, to see more about them, take a look at our website, thinkeatplay.org. But many of the folks that are here today are part of our advisory panel, and I am just thrilled. Think, Eat, Play is really the updated and energized and revitalized version of a program that we had done back in 2001. Nobody was talking about the Triad back in 2001. But this was a program through the New York State Public High School Athletic Association with support from state ed, lots of financial support and philosophical support. And we also had a lot of support from the American Dairy Association and Dairy Council. And that's when we really developed the Female Athlete Triad recognition and awareness program. The components of the program included a manual, which was, I think, pretty fabulous. And I won't bore you with all the details of the manual at this time, but there's a pre-participation questionnaire and flow charts and case studies and lots of sports nutrition information, training diets, pre-competition meals, recovery information, classroom and team activities that included goal setting, problem solving, and self-assessment. The American Dairy Association also developed a great video for us called The Dangers of Dieting that was designed for use in the health education classroom and even at team meetings. We also had gotten the rights, remember, we're talking about videos, this is 2001. The original video developed by ACSM on the Female Athlete Triad, and we used this video when we were training coaches and, school nurses and primary care physicians. We also had posters done that were really fun, and those posters were displayed in locker rooms and in cafeterias and in classrooms and even in some of the medical offices. Pediatricians' offices were hanging up these posters. A big piece of the training of the program, I should say, was a training, and that's the way we were able to train 85% of the school districts throughout the state of New York in the understanding and recognition and management of the Female Athlete Triad. And school districts would come as a team of professionals, coaches, athletic directors, principals, athletic trainers, school nurses, and school physicians. And they would all come together, and then we would give them the information in the morning, and they would develop action plans in the afternoon. And it was really exciting and very dynamic. Big piece of what we've done moving forward with Think, Eat, Play is under the fearless leadership. I don't know if Emily's here. I'm sure she is someplace. Emily, raise your hand. Just need to see you. Yeah, there she is, all the way back there. Okay, under the leadership of Emily Crocious, we've developed a really exciting survey assessing the knowledge, attitudes, and resource utilization of coaches. And it's been really exciting because the whole purpose of this study is we needed to figure out this time around, as opposed to perhaps what we did the first time with the Athletic Association, is we needed to figure out what do the coaches know, what are they interested in knowing, and how do they want to receive that information. So with this survey, we're now able to fill in these knowledge gaps and really develop appropriate educational materials accordingly. So just some highlights of the study. I know Emily's still in the midst of culling all the data at this time. But we know that 67% of the coaches have actually heard about the female athlete triad. 37% reported that they could identify the 3 conditions. However, only 13% were able to correctly identify all 3 conditions. We also found significant differences by coach gender. No surprise here a little bit. Females rated menstrual disturbances as more harmful than male coaches did. Male coaches were more likely to discuss achieving an ideal body weight for performance than female coaches were. And male coaches were also more likely to talk about restricting particular foods in order to achieve that ideal body weight. This is really interesting. The topics of interest that are important to coaches, 88% want to know more about sports nutrition. Yay, nutrition. 73% are interested in learning about disordered eating. Really confused about that. The coaches were. 65% want to know more about menstrual functioning. 72% want to understand bone health better. 80% want information about strength training. And you can't see it, but 88% reported that it would be useful if their school provided a pre-participation questionnaire to begin to screen a little bit more than they're currently doing. So from 2012 to 2013, Think Eat Play is brand new. I mean, we've been at this for less than 8 months now. But we've developed the coaches survey. That's been exciting. As a result of the coaches survey, we have validated that coaches really look to the school nurses when they are concerned about an athlete. So now we want to make sure that we're filling in those knowledge gaps with the school nurses, so we're assessing the school nurses as we speak. We've developed a website. It's really exciting. We've got 8 pilot districts in North Carolina that we're working with. In the state of New York, where I am on Long Island, we've got 5 pilot districts, and we are actually in the middle of survey monkeying, just assessing a coach's handout and a parent handout, just to see if this is the information that they're interested in, what are they doing with this information, how are they using this information about the triad. Some of the handouts that we've developed to date: Triad Talks by Marcy Goolsbee, Emily Crocious, Whitney Post, Nutrition Game Plan, that's kind of my thing that I've been doing for over 20 years, Intuitive Eating Information by Elise Resch, Exercise Addiction by Carolyn Costin, How to Talk to an Athlete, inspired by Kathy Beal's work, and then we've got some really interesting information from the research from Jessica Arthur on advice for coaches and parents. And all these handouts are downloadable on our website. We've got this really fun awareness bracelet campaign that Kate talked about. Really cool. They're fair trade bracelets, and it's just a little simple awareness device, but with a little hang tag on here that says, "Did you know girls who don't eat enough calories may develop menstrual irregularities, which can weaken bones and lead to other serious health problems?" Simple, but sometimes simple is enough. That's all they really need to know. So we're using this almost like like the rubber bracelet programs. We're right now in collaboration with New York State Association for Health, Phys Ed, Recreation, and Dance. And this is really exciting because it really gives us a great platform in which to roll out all of our materials. So we'll be traveling around the state of New York over the next year and a half in all the different zones throughout the state, talking about the triad and really rolling out all the programs that we are actually right now in development with. We're developing webinars and films and updating those lessons that I talked about in the manual before. We're developing some student-led initiatives. I've got an amazing intern that's helping with that. We've got an ambassador program and a playbook that we'll be distributing to all schools. So that's it. Questions? If you want to get involved, give me a call. Thank you.
Okay, so now we're going to have all the speakers come up and sit at the table for a few minutes of questions. Awesome, right there.
So for teenage athletes who are amenorrheic for maybe a number of years, are there any future fertility effects from that time period? I'm a physician and I'll have patients ask me all the time, if I don't have my period during track season for 3 years in a row, when I'm 30, will I have trouble being pregnant?
So it really depends upon what their status is at the time that they desire fertility, and if they are recovered and getting regular human a week, if they're human a week and getting regular ovulatory cycles, it should not be an issue. That can resume with optimal energy availability. Of course, if there is a persistence and fertility is an issue, there are strategies that are very effective. The assisted reproductive technologies will help.
It's interesting you bring that question up because during our hormones and performance talk yesterday, Carolyn Silby brought that up, and some of the other people in the audience asked about that. And when I was in medical school, I had that same exact question. I had finished being on the U.S. rowing team, had been a lightweight rower, worked with a lot of lightweight rowers, and thought, some of my older colleagues are now in the time of their life when they want to have kids, and I'm noticing a lot of them are adopting. So I actually contacted, being a naive little med student, contacted the IOC and said, hey, do you think we could send a survey to the 700 plus women, this was over a decade ago, who have been national team athletes and find out if they had any fertility problems? And like Dr. Thompson, and he's shaking his head, the initial response I got was, no, absolutely not. It would be bad for female athletes. We don't need to send a message that sports are bad for women. So I'm hoping with people like this, who are very strong proponents of doing things and getting more information, we might be able to resurrect that idea, because certainly it makes sense if you have disordered eating and that carries into adulthood, you could have some fertility problems. But is there something else that we're missing, that if you suffered way back when, are there issues in your mid-30s? And I don't think we really truly have that answer for everyone.
There was some data from a study that Jan Hall did many years ago, but that was a study in hypothalamic amenorrhea. So it included eating disorders, it included athletes, and it included women with stress-induced amenorrhea. But those are the only data we have at this point.
Go ahead.
I'm a nurse practitioner, and my question is, with these amenorrheic athletes, at what point clinically in primary care, as opposed to research, do you order a DEXA? Is it just kind of an educational message to the patient, saying, look what's really going on, or risk-benefit versus radiation and cost and all of that?
Yeah.
How is it used? How important is it?
So that's a great question. When do you get a DEXA for an athlete who is amenorrheic? And it's interesting that you asked this question, because we just got back from the ACSM and a symposium where we talked about this, and we have a working committee that's coming up with guidelines regarding when to get DEXA scans, when to consider treatment, and so on. And so you'll hear more about that, and we'll be publishing those data. But basically, if you have somebody who's fracturing, obviously you want to get a bone density test. If there are various components of the triad that you worry about, or different risk factors, so depending upon body weight, depending upon the duration of amenorrhea, those would all be concerns. So, so it's usually a combination of those factors, but certainly in somebody who's fracturing, you want to know what the bone density is. Oligoamenorrhea for 6 or more months. Body weight is an issue that is hard to get around, because do we go by percentile body weight, or do we go by BMI? Do we go by weight loss over time, or a maintenance of low weight over time? So those are all factors that we're grappling with right now, and when we come up with the guidelines, hopefully you'll have some better direction.
Yeah, I'm talking about people who aren't necessarily underweight, and even not necessarily athletes, but just...
Yeah, so that's exactly...
The other question is when do you get bone labs and vitamin D levels and all of that? It's not really eating.
Right. So that's exactly what we grappled with, because not everybody is low weight. And the girls that I showed you in the study that we're doing, nobody is low weight, because we're recruiting people who are normal weight. And so the guidelines have come up with many risk factors. And so what we're saying is that if you have 2 or more moderate risk factors, if you have 1 or more high risk factor, that's when you get a DEXA scan. And so, we'll have those guidelines for you.
I think those guidelines are extremely comprehensive, and obviously they need to be published. I know clinically what I do, it's not a super hard decision about the DEXA part. A, it's really cheap. B, the DEXA has less radiation than flying from here to Colorado on a plane. So when we're talking about radiation risk, it's extremely low. And 3, insurance will pay for it for a lot of indications. So I don't think that's as complicated as do we order the huge bone lab set. But when those guidelines come out, I think you walk through the guidelines pretty easily. It helps make that decision.
So vitamin D levels should be, again, not very expensive to get. So I think that's easy enough to get in somebody who's amenorrheic and you have concerns about bone density. The rest of the bone labs I would probably reserve for somebody who has low bone density on the DEXA scan.
In the back.
Okay. Will the upcoming guidelines give us some guidance around sort of a line in the sand for participation in bone density levels?
I'm sorry?
So they just wanted me to repeat the question for the recording.
Yes.
She wants to know if the guidelines that are coming out will give some understanding about when you restrict an athlete from participating.
Absolutely. So the guidelines will take into consideration bone density, body weight, status of amenorrhea versus oligoamenorrhea, and I can't remember all the others. Stress fractures, and maybe the kind of sport that may have that may be one of the modifiers. So it's going to take into account all of those factors.
And the athlete's willingness to participate in her own recovery too. Right. So, yeah, so there'll be some pretty straightforward return to play guidelines. And you have to remember they are guidelines. But so yeah, we're excited that it's after a year and a half to 2 years of working on this. It's very close now. So
go ahead.
Dr. Nichols, when you were talking about the athletes, the runners, distance runners who are at a greater risk of losing bone mass with the high school athletes, I'm just wondering, are they athletes that are just doing distance running? Are they athletes who are involved in multi-sport so that they may do cross-country in the fall and track in the spring? Are those the athletes, or are they just a distance runner?
So just to repeat for the recording, the question is asking about Dr. Nichols' research about running athletes and what kind of running athlete they were, if they were cross-country, a triple sport athlete.
Most of them are year-round distance runners, so they run cross-country, and well, it depends on the geographic location, but it's fall in the West Coast. They'll do winter track, and then they'll also do distance. You know, they're usually the milers in spring track. However, some of them are also playing club soccer at the same time, a few of them. So, and then let me just kind of back up and say, our hypothesis is that perhaps these girls aren't, except in some of the extreme cases, are actually losing bone. We believe that this mild but chronic energy deficit created by this imbalance between their very high expenditure. So the average distance per week was about 40 miles that most of these high school kids are running. And then if you add to that another sport, they have extremely high caloric needs. And so they may not be losing bone, but we think they're probably not gaining it at the rate. And those cross-sectional data on the last slide on the age suggests that it's just not being laid down at a normal rate. Fortunately, that's not a high percentage of girls, but it's still it's real. It exists. So the high energy expenditure of running in itself, or if they're compounding that with another sport, they don't have time to eat. They just are not getting enough calories. So we're trying to get at that inadvertent, low energy availability. And we just presented an abstract at the ACSM meeting last week, where we tried to statistically, look at those who have low energy availability, with or without the disordered eating, based on the other conditions. It's kind of tough to get at, but we suspect that there are a number of them, at least in the early stages, are just unaware. So that's where the education and the retraining. And there is a study that is underway at Penn State University by colleagues of ours, where they're doing it's called a refuel study, and they are feeding runners, and these are recreational runners. They're not necessarily Penn State athletes, but recreational runners, and they are refueling with using an energy bar as kind of an easy way to do that. I think 3 or 4 times a day, 100, 130 calories each, just to bump that energy up a little bit. And so very soon we're going to see data coming out from that. So, thanks.
We have time for a couple more questions. Go ahead.
Dr. Thompson, I know you said that you've done work with NCAA.
Yes.
And I've seen a lot of your stuff, and I'm just curious if you know how many schools have sort of picked up having resources on campus, having, these available for people who are having problems.
So just to repeat, sorry, no, that's annoying. I think the question was, we know Dr. Thompson's done awesome work with the NCAA. How much are the schools in the NCAA really implementing what they're doing?
Yeah, it's an excellent question, and to be perfectly honest, I don't know, and I don't know that the NCAA knows. The document that I'm assuming you talk about is Managing the Triad, the coach's handbook that we did, that we wrote specifically for coaches. And again, as I mentioned earlier, Roberta and I believe the coaches are the key players here. And what we tried to do was to put together basic information. Now, it's certainly not prevention like the quality stuff that Carolyn's going to talk about. But what we wanted people to know is just sort of the basics about the female athlete triad. We had done a study in which we at the NCAA, where we talked to over 3,000 coaches of female athletes. And we asked them what they wanted to know. They wanted more information on the triad. So that's where the document actually came from. And when we actually wrote that document, our coaches at Indiana University, who have been fabulous, worked with us because, let's face it, if you're going to write something for coaches, it needs to sound like it came from coaches and their language. And they helped us do that. The NCAA was very good. They sent those documents to every one of their 1,015 institutions, D1, D2, D3. How many coaches used them? I don't know, but I can tell you this. A lot of athletic trainers use them because the athletic trainers tend to be the folks who actually are charged with their care. So, unfortunately, that's all I can tell you. I don't know. I hope it's being used. But, again, your guess is as good as mine.
One more question. In the back.
One point, and I just wanted to wonder about the studies, is that you mentioned that their normal weight is their BMI, which would be 10 and 80 percentile. And I think one of the key things with a lot of these athletes is that it's not a normal weight for them. And so although they're still technically in the normal range, they've gone from being a kid who's thrown at the 75th percentile, they've dropped to the 30th. And because they're still considered normal, they don't get that red flag sometimes from the pediatrician, but it is a huge red flag. And those kids often are sicker than the kids who went from 10th to 5th, or officially kind of raised the red flag. So I guess my question is in your study, do you actually look at their old growth charts, kind of have any indication that this is a normal weight truly for them, or it is just for the study purpose? Because I think that's a message that they need to get. And Amy Gardner talked about in her talk that it's really important that sometimes these kids is just not normal weight for them.
Absolutely. So I think that's extremely important. And in fact, in the return to play guidelines, weight loss is a very important component of one of those risk factors. And in our study, we are looking at BMI percentiles, as you mentioned, but we are also asking about the highest weight that they've ever been at, the lowest weight they've ever been at. So we'll be, certainly taking that into consideration. We also ask about eating disorders. We actually have a study psychologist who asks about current eating disorders.
So I think that's all the time we have for this panel. Please help me give a round of applause.